Good evening, everybody, and welcome all of you to the live program number 164 at Orthopaedic Principles. Today, our guest of honor is distinguished faculty, Dr. Alfonzo Manzotti from Milan, Italy. Professor Manzotti completed his orthopedic residency at the Università degli Studi of Milan in 1998. He also did a clinical as well as a research fellowship at the University of Maryland in Baltimore, United States. Following which, he joined as consultant at the CD Hospital in Milan, Italy in 2001, where he worked till 2015. Subsequently, he took over as the chair of the orthopedic department at the Luigi Sacco Hospital at Milan, Italy. Dr. Manzotti is also professor at the Università degli Studi of Milan, Italy, and also the teaching faculty at Politecnico di Milano Engineering University and also at the University of Molise since 2011. He has several publications in international journals of high impact and is author or co-authors in 13 chapters in textbooks. His prime interests are in customized joint replacements with minimally invasive approaches and small implants. Today, it's my great honor to introduce you to Dr. Alfonzo Manzotti from Milan, Italy. Over to you, Professor.
Okay. Thank you. Thank you, Professor Gopalan. It's a pleasure and honor to be here with you to discuss with you particular topics in knee reconstruction surgery. Patellofemoral arthroplasty is really a less common surgical option in knee reconstruction surgery. And we will share which are the best indication and the nowadays result of this partial knee replacement. Just one slide to speak about the story of this implant. The first implant was performed in the 1955 by McEwer. It was just a screw on a Vitalium patellar shield, leaving in touch the trochlea, and this was the main cause of the failure of this implant, because an obvious huge trochlea bone loss. Later on in the 70s, on the market were available the Richard prosthesis by Smith and Nephew, and Richards obviously, and the Rubinus implants. Both were the first generation of inlay implants. We will see later on what does it mean inlay implants. We have to start to understand if there is a room, there is space to use this implant in reconstruction surgery. And we have to look at the literature. And looking at the literature, some radiological study shown that there is an effective space for this kind of implant. About 20% of especially female patients can be suitable for this kind of implants, but it's still a niche product. What does it mean, niche product? It's like a particular Italian foods, like some particular wine or ham, or like Parmigiano cheese, which are appreciated but just few clients. But if you want to understand better what is a niche product, we should look at numbers. And the better way to understand and to see number is to look at the National Joint Registry. And if you look at the UK National Registry in 2017, the numbers are very clear. In 2006, there were performed less than 2% implant in patellofemoral arthroplasty, which was the same number in 2011, and which was the same perfect number in 2016. But if you want to be even more precise regarding number, we could look at the Australian National Arthroplasty Register, and we see that in 2018 were performed about 800,000 knee replacements. But among these, less than 8% were partial knee replacement. And if we want to look at this partial knee replacement, less than 7% of partial knee replacement performed in Australia were patellofemoral replacement, which means less than 4,000 implants compared to a total 800,000 implants per year. But which kind of implant we have available? We have mainly two types of implant. We have a symmetric design and asymmetric design, which means a sort of patellar friendly design. But the big difference among the implants available is based on two main family: the onlay implants and the inlay implants, which could be divided in full trochlear or partial trochlear implants. What does it mean, onlay implant? Onlay implant is a sort of half knee replacement, half femoral shield, which means that it's well and fully instrumented implant, even using intramedullary guides. Is based on an anterior femoral cut as well as in TKA procedure. Usually is a broad trochlear flange, trying to reach a valgus tracking and trying to achieve a high congruency between the patella and the trochlea. The only implant are quite different. It's a different concept. It's a sort of, it's a more resurfacing implant, because this implant aims is to replace just the trochlear cartilage, leaving intact the subchondral bone, trying to achieve a rotational alignment parallel through the trochlea original inclination. Obviously, with a poor mediolateral coverage, which means also a smaller implant. The first generation, I already told you that the first generation, Richards and Lubino's plants were inlay implant, were very poorly instrumented, which means a surgical procedure based mainly on the surgical skill of the surgeon. But up to now, there are the new generation, a third generation of inlay implant, based on the new technology like patient-specific instrumentation, computer-assisted technology, or even robots. But the inlay implants could be even divided in full trochlear implants which try to replace all the trochlea, or there are even available some partial trochlear replacement, which try just to replace focally the damaged part of the trochlea. What about indication? As in many orthopedic fields, there are some classical and well-accepted indications, but there is obviously some contraindication, and there are, as in many fields, some debatable indication that in patellofemoral arthroplasty is mainly due to the surgical experience of the surgeons. As well-accepted indication, as well classic indication, is obviously a primary isolated symptomatic patellofemoral arthritis is the first classical indication. But even following trauma or some surgery, previous surgery addressing the patellofemoral joint, like trochleoplasty, or some any realignment procedure like Mackay or Firestone procedure, which can cause secondary arthritis, could be a good indication for a patellofemoral replacement. But even the trochlear dysplasia associated to a mild patellar teeth could be other classical indication. All in this case, the arthritis grade according to Ivanhoe classification should be at least equal or superior to grade 3. There are obviously some contraindications. It's obvious that an active infection or a chronic regional pain is a bad indication for any kind of replacement in any joint. Pluricompartmental arthritis, especially if symptomatic in many different compartments, is not a good indication for a partial knee replacement, any kind of a partial knee replacement. A patellofemoral arthroplasty is not capable to address a severe limb deformity or a very bad patellofemoral malalignment. And even some inflammatory joint disease like rheumatoid arthritis are a contraindication for this kind of implants. There are also some debatable indications. Some surgeons, especially trained in this kind of implant, can try in particular case to extend indication. For example, there are some surgeons suggesting to treat even bicompartmental or tricompartmental arthritis, but with just the symptomatic patellofemoral joint, with isolated patellar arthroplasty, or with association with other partial knee replacement, for example, uni plus patellofemoral replacement. Obviously, an isolated patellofemoral arthritis associated to instability or patellofemoral alignment could be addressed with the association of isolated patellar arthroplasty with some other surgical procedure trying to address or either stability or the malalignment, as well as for the patella bias, which could be corrected with some anterior tubercular osteotomy. These some pictures taken by my previous experience. It was a 8 years follow-up showing some partial knee replacement in association implanted for tricompartmental arthritis, and including the use of a patellofemoral arthroplasty. But which could be the ideal patient for this kind of procedure? According to literature, the ideal candidate for this kind of selective knee replacement should be a relatively young patient. According to literature, younger than 65. Should be not an obese patient. Should be owns a good muscular trophism in a stable knee, without limb deformity, especially inflection, and obviously with a good range of motion. But even in this case, the literature is starting to show that some authors are extending the indication. For example, some authors in literature are publishing some papers showing that obesity, for example, is not a contraindication, and these authors report good results performing this kind of partial knee replacement arthroplasty even in obese patients. And what about patient age? According to the classical indication, ideal patient should be a younger patient, but some authors in literature are thinking to perform less invasive surgical procedure even in tricompartmental osteoarthritis patient, especially in older patients for which own some indication for a high aggressive surgery. For example, in very in sick or multipathological patients. And what about ACL as a contraindication? But even in this case, in literature, looking at literature, there are more than 12 studies in which no one of these authors show that an anterior cruciate ligament deficiency is a contraindication to perform a patellofemoral arthroplasty. And what about the mechanism of failures? Usually this kind of prosthesis trend to face early or later on. And for this reason, there have been described two kinds of complication: early complication or late complication. The most common early complications are an early onset of anterior knee pain, as well as a patella catching or snapping, or, for example, intrasurgery or post-surgery extensor mechanism rupture, which could be not so rare, especially in performing this kind of arthroplasty following previous surgery or trauma case or fracture. And even the arthrofibrosis could be considered as an early complication. What about the late complication? Progression of the arthritis to the other compartment, which is the most common reason for failure of this kind of prosthesis, could be considered as a later complication. And obviously, even the component losing could be considered as a late complication. But we don't have to forget that there are other kind of reasons which can make our implant fail, like technical errors. For example, some error, some malpositioning of our implant, some mistakes in component sizing, for example, an overhang, or a poor soft tissue balancing, as well as not addressing any correction of the patella high and leaving a patella baja if present. Could be a cause of consequent failure. What about the literature? Literature, we found a good report. These are some papers that everyone can find on literature showing very good survivorship. Ranging close to 95% at even a longer follow-up. I indicated follow-up ranging from 5 to 18 years follow-up. But there are also some other papers showing not brilliant results with a potential average of failure close to 40% at the similar follow-up. But if you want to be again more precise, we have to look again to the national registry. And we look at this registry, this is a British arthroplasty registry. We found that at 10 years follow-up, many of these implants fail a lot, close to 50% to 20%, which an average even more at later on follow-up, close to 25% at 15 years follow-up. And with a survivorship clearly worse compared to other partial knee replacement. The most amazing result is from the Australian registry, which shows us an average of failure close to 45% at 16 years follow-up. Very impressive. But why this implant failed? Which are the most reasons to fail? This is one of the biggest series of revision of patellofemoral arthroplasty, and we see, as I already told you, that the most common cause of failures is osteoarthritis progression to the other compartment. But up to now, close to 20% of our implants, we don't know which is the cause, because for example, an unexplained pain or an not recorded case. So it's still debatable why this implant fails. What about the result according to the different family of onlay and inlay implants? This is a paper from the ESCA journal showing that there are no difference in the outcomes between inlay and onlay implants, maybe with less progression of the arthritis process in the inlay design. And what about the comparison to a total knee replacement? Up to now, even this kind of comparison, there is no difference in the outcomes. Even if more recently, a paper on the clinical orthopedics show in appearance a faster recovery and early better outcomes in favor of the patellofemoral arthroplasty, but with a similar outcomes at 2 years follow-up. And what about the usual association of partial knee and of uni and patellofemoral versus total knee replacement arthroplasty? We published several papers. This is one of the last paper, and even in our experience, we didn't find any difference between B compartment and total knee arthroplasty. Which could be the future of this implant? Maybe the new technology will help a lot in performing this kind of implants. There is few paper dealing with the use this customized new implant. This was again a paper from the ESCA journal at 2 to 5 years follow-up, showing a very good survivorship with a significant improved clinical outcomes and patient satisfaction. In conclusion, we have to know that we have two implants available. We have inlay and onlay. Onlay is a sort of half knee replacement. Inlay are more resurfacing procedure with a smaller implant. Onlay is a inlay implant try to keep the same trochlea as well as the native one. But in conclusion, we have to remember that this is a knee surgery. In the world are performed less than 2% of all the knee replacement are patellofemoral arthroplasty. A knee implant, I repeat again. The older design tried to fail a lot. At 15 years old, 15-year follow-up, some registry show an average of failure close to 40%. According to some classical indication, the better indication should be younger patient. But the most important point, I think, is this, that this surgery should be reserved to very experienced surgeons who train in partial knee replacement. And maybe in the future, new technology like customized implant or robots or computer-assisted surgery could help this technology, this type of implant, to be more used among the knee reconstruction surgeons. Thanks.
Thank you, Professor Manzotti, for that excellent presentation of yours. It was nice listening to you. Few questions. Now, in case you're going to revise a patellofemoral replacement, are you concerned about significant femoral bone loss?
According to my experience, no. Honestly, I have to say that I'm more concerned about revising a unis than a patellofemoral implants. And I also have to tell you that there is a big difference between revising a onset implant than an inlay implant. I think that inlay implants are easier because they are smaller to be revised compared to an onset implant. This is very important.
Prof. Manzotti, actually, you can stop sharing your screen. There's an option called stop sharing in the bottom.
Sorry?
The screen, you can stop sharing.
Okay, stop sharing. Okay, stop. Perfect. Okay. Sorry.
Yeah, no issues. And see, Prof. Manzotti, you looked at the National Joint Registry in the UK, as well as you looked at the Australian Orthopaedic Association Joint Registry. And can we take home the message that at 10 years, the current registry states that the revision is around 20%? Because you said the A1 arthroplasty, the revision at 10 years is around 46%. And in the NJR, the revision is close to 20%, isn't it, at 10 years? So is that the message that we can take? That 10 years revision of patellofemoral arthroplasty is going to be around 20% or less?
Yeah, I agree. I definitely agree with you. I also to say that the British registry is mainly based on onlay implant, because we have mainly three generations. The first generation were the inlay implants, Lubinus and Richard, which has already almost failed. So there are no patients with this kind of implants, unless very few cases. So the British registry is mainly based on the second generation, which were these onlay implants. Now there are this third generation, which are mainly inlay implants, which maybe in the future can show longer follow-up, maybe in association with this new technology. But the actual result, according to registry, which is mainly based on onset implant, are about 20% of failure at 10 years follow-up, which is quite high.
Thank you for that, Professor. The other question is, do we have, say, 5-year results of these third generation implants, or what is the longest follow-up we have?
If I want to zoom, you have you have to consider that one of the biggest company producing this only implant 2 years ago retired this implant from the market. If you go to look, you should know, you could find which is one of the 5 biggest company, and it was an inlay implant. The problem is to understand why they had to retire this implant. I think that there is in judging the result of patellofemoral arthroplasty, there is a huge bias. As all of the arthroplasty register, they don't consider the surgeon experience. So it's very easy to say at 10 years, this kind of implant is going to fail at 10%. But we should, if we want to be very honest, we should look in which center this implant fails about 10%. Maybe there are in some center where the surgeons are very trained, they are very experienced. The average of failure, I'm convinced about this, the rate of failure is very low. The main bias is this: there is no analysis of the surgeon experience.
Thank you for that, Professor. In that particular scenario, can we think that the patellofemoral arthroplasty can be considered as an interim procedure before a total knee? Because you said the revision to a total knee is not very difficult, isn't it?
Yes, definitely, I agree.
So you do a patellofemoral, and later on, if the patient requires, you can easily go in for a standard total knee, isn't it?
Yes, I do. I do isolated. I do in association with a partial knee replacement.
Okay.
And I don't have any. I don't see. I think it's very important training, the experience to understand which is the best patient, and you will get very satisfied patient because we will keep a normal knee kinematics. And leaving your door open for some other surgical procedure in the case of worsening of the arthritis or patellar arthritic progression to the other compartment. But the problem is the main issue is to select the patient and to have a training in this kind of implants. Then you will find the correct indication. I'm sure about this.
And what are the common complications that you have met with? I'm sure you wouldn't have had major complications, but what are the few minor complications that you have had in your experience with these third generation or second generation?
Not addressing the patellofemoral alignment. This is the problem. If you have a patella bar, you have to correct this. If you have a maltracking, you have to correct this. This is the main problem. It's not enough to replace. You can also, it's like an osteotomy. You have to address the correct indication. If the cause is a patellar maltracking, you have to correct the maltracking. Then you have to replace the damaged part of the patella. This is very important. If you just do the replacement, just to say, okay, I have performed a patellofemoral arthroplasty without addressing the cause of the articular damage, you are going to failure for sure.
And in that particular scenario, do you require an additional procedure? For example, an osteotomy. Have you done an additional procedure like lateral? Of course, lateral release is a very common procedure, but is an osteotomy or something that you do along with it?
Not so common, but when you need it to do, you must do it. You have to select the indication. If there is a maltracking and you cannot correct with your surgical procedure, with the offset implant, with the only implant is easier because you just do a half total knee. But if you are doing an inlay implant, which just leave intact your trochlear alignment, so you have to correct. It's impossible to try to correct a maltracking of the patellofemoral joint just with an inlay implant. You need to address both. If you have a patella baja, you have to correct. Otherwise, there's no sense to do this.
Okay. Thank you, Professor. I think that's all the questions that we have. Thank you for that fantastic presentation. A lot of new insight. A lot of, I mean, your experience really added so much of value to the data that you presented. Thank you so much for joining, and we'll really look forward for another one more lecture from your side whenever you're free.
Okay, thank you. It has been a pleasure. It has been a fantastic time spent with you. Thank you.
Thank you very much, Professor.
Bye.